Hi, all. Thanks so much for joining us for today's webinar, Recovering and Expecting Why Medications for Opioid Use Disorder Are the Gold Standard During Pregnancy. So this event came about. R Street recently published a paper on state policies related to substance use during pregnancy. And during this, we found that most states do indeed penalize people who consume substances during a pregnancy, regardless of whether or not that substance is legal. Of those states, almost 24 offered no protections or insufficient protections to women who are taking prescribed medications during their pregnancy. So this means if an expectant parent is taking methadone or buprenorphine, both FDA-approved gold standard medications for opioid use disorder, that they risk losing custody of their child when it's born. They can even face criminal charges in some cases. A 2024 investigation looked at 8 states in DC, and they found that nearly 3,700 women had been reported to Child Protective Services since 2016 just for taking a prescribed medication for opioid use disorder during their pregnancy. Sometimes I will refer to medications for opioid use disorder as MOUDs. Some people refer to it as MAT or medication-assisted treatment, but we'll commonly use MOUDs for shorthand during this panel. And then between 2022 and 2023, at least 133 women in the US were criminally charged for substance use during pregnancy. And 16 of these were taking MOUDs. So we know that in the vast majority of cases, parents and children do better when they stay together, both physically and emotionally, psychologically. So these policies put a lot of pregnant people with opioid use disorder in this sort of impossible position of feeling like they need to choose between losing their child or facing other life disruptions and penalties, or endangering themselves and their pregnancy by quitting their medication altogether. So today, what we want to do is start by providing a little bit of context about why medications like methadone and buprenorphine are considered the gold standard treatment for opioid use disorder, and why they're so important during pregnancy. So to do that, we've got a great panel who's going to draw on medical expertise, clinical and lived experience to discuss the safety of taking MOUDs during pregnancy, some of the long-term outcomes for parents taking MOUDs and their children, and benefit some of the long-term health outcomes for their children as well. And how state laws finally affect the treatment options. So I'm going to do quick introductions. We have Joelle Puccio, an RN, and they've been a nurse with a NICU nurse since 2004, working at 16 facilities in 10 states, providing harm reduction and direct services in 4 states since 2010. They're a co-founder and director of education with the Academy of Perinatal Harm Reduction, and a person who uses criminalized drugs. Mishka Turplin is a medical director, MD, is a medical director and senior research scientist with Friends Research Institute. He's board certified in obstetrics and gynecology and addiction medicine, and is a co-founder and co-director of Doing Right by Birth. Finally, Rachel Hernandez is a recovering heroin user and single mother of her 4-year-old daughter, Raiden. She's been on her road to recovery for over 4 years now, and she currently provides feedback and works with Our Lady of the Angels Hospital, which is the Louisiana hospital that actually provided her with support during her pregnancy, and that support included prescribing Subutex, a form of buprenorphine. And as a patient, so she does this as a patient with lived experience, and she has also spoken at the 2022 LAPQC Perinatal Neonatal Quality Improvement Conference and acts as a patient advisor to the Louisiana Perinatal Quality Collaborative's Improving Care for the Substance Exposed Dyad Initiative. So I'm super excited, really thankful to all of you for participating, excited to have participants here. Our chat we'll be sharing some resources occasionally in the chat. But if you've got questions, please use the Q&A, and we will make sure to try and get to those either during if it makes sense, or we'll try to hold on to some time at the end. So before we kind of get into the benefits specifically of MOUDs during pregnancy, I want to get some context as to why this matters to begin with. So Mishka, I'm hoping, Dr. Terpling, can you provide us with a bit of a sense about the degree to which opioid use disorder is a risk during pregnancy?
Well, I thank you, and thank you for hosting this and for inviting me, and I'm really looking forward to this conversation. But I struggle a little bit with the term risk because and I'll unpack that shortly. And there's really kind of like three points I want to make as context. The first is when we talk about opioids in pregnancy, really we're talking about three different populations of folks. We're talking about people with untreated opioid use disorder. We're talking about people with opioid use disorder that's treated with a medication, either methadone or buprenorphine. And third, we're talking about people who are using prescribed opioids for a chronic medical condition who do not meet criteria for a use disorder. And those are three distinct populations with different needs. And if all we look at is like the result of a positive drug test at the time of birth, we actually can't distinguish, between those three things. The second point really is like, what is our unit of care, like clinically, and I think also from a policy, perspective. And that really should be the dyad you know this space is peopled with all these like sort of false oppositions, and that's where the terminology of risk sort of comes in. The rights of the fetus versus the pregnant person, the infant versus the mother, the pediatrician versus the neonatologist, the doctor versus the nurse, and doctor everyone versus the social worker, and etc. And those are all false, because I think, and unless we sort of take a step back and conceptualize, or reconceptualize or speak to, sort of the dyad as the point, as what, like what the care is, that's the way around, those oppositions. And finally, there is a decent burden, in particular for maternal deaths related to opioid use disorder. More people use other substances in pregnancy than opioids. Maybe 2% of births at the most, nationally are complicated, quote unquote, by opioid use disorder. But when we look at maternal deaths, we have an epidemic of maternal death in the United States. Almost every state that counts this, like, overdose and or drugs are part of the majority or the plurality of deaths within the state. And almost all of those are happening postpartum, not during, sort of the prenatal care period, which speaks to, like, and we'll talk more about this, like the importance of providing, chronic management for chronic conditions.
Thank you. I think that's a really that the importance of looking at the dyad, right, is a big part of why we're here today and what I think it's important that we continue to talk about. So I'm really appreciative of you bringing that up. And I think even when we're talking about maternal deaths, right, we're talking about like due to overdose or other complications. This is also affecting the dyad. This is affecting both bodies. So, Joelle, would you want to add anything to that with regard to risk or
I'm right there with Mishka. I also I don't really like conceptualizing it as what is the risk caused by this, because I don't really, I'm kind of answering the next question at segueing into it a little bit.
yeah,
But
go for it.
the risk that is posed inside the body by the substances themselves is pretty minimal when compared to the broad scheme of things. Most of the risk comes from the way that we treat people who use opioids in our culture. Um, Criminalization, I don't really have a good word, criminalization or stigma or whatever you want to call it, the way that we categorize people as something other, um, bad or good, all these dichotomies, that is what does most of the harm. That kind of conceptualization of certain people as bad or criminal or stigmatized, that's what causes or exacerbates all of the harms that we're talking about today. These substances, if we had a regulated, safe supply, would be incredibly safe for use during pregnancy. And they are used, like Mishka was saying, for pain during pregnancy quite frequently. The opioids are not the problem. The problem is the context and the way that we criminalize people. We isolate them from social supports. We refuse them services. We don't allow them to have places to live or jobs or ways to interact and contribute to society. And that is what is causing all of the damage.
So when we think about that isolation, one of the things, like, can you provide some examples? Like, one of the things that comes to my mind is potentially not wanting to go seek care with a provider during your pregnancy if you're taking opioids. Is that the type of thing? Or are there other examples that might come up that show up as a problem?
People don't want to seek care because they are afraid that the provider is going to be mean to them. And unless you're going to Mishka or a handful of other providers, that is accurate. They are going to be mean to you. Um, that's just a fact. And people know that because they've gone to the hospital, they've gone to the doctor before. Excuse me, I have kittens in the background that are causing havoc. Um, so that's part of it, but it's also you can't go on a vacation because you will start to withdraw and then your mother-in-law will notice. You can't function um, socially without people noticing what's happening with you. And that creates a great deal of isolation. You also just can't, having to always hide a kind of big part of your life, a big relationship that you have with this substance can be really damaging to your psyche. Just thinking that if people knew who I really am, what I really do, then they wouldn't love me anymore, or they wouldn't think I'm a good mom, or they wouldn't let me watch their kids. And that's true. It's not that people are thinking this out of nowhere. This is accurate. The way that we treat people who use substances does not line up with the way what we say we believe about people who use substances.
Thank you. So because of these risks, arguably maybe more because of the stigma and the assumptions that are made about substance use and opioid use in particular during pregnancy, right? A lot of people make the argument that, well, if you find out you're pregnant and you have an opioid, you should just quit. Just go cold turkey and quit. And this is something that I had the privilege of chatting with a bit with you, Rachel, about when we first talked. And you talked about sort of your fears when you first found out you were pregnant and what you went through. And can you kind of walk us through what was going through your head?
Yes, absolutely. Thinking back to that time when I found out that I was pregnant, even now, all that comes to my mind is fear. You know, all I felt was fear because everything around me about that was just negative. You know, I was told all kinds of different things. I was told, well, you can't stop using because if you just stop using, then you withdraw, then your baby withdraws, and then you risk a miscarriage. So I was like, okay, well, I'm not going to do that. And then I also heard, oh, you can't go to the doctor. If you go to the doctor, they're going to treat you terribly. They're going to test you and see that you're using, and they're going to arrest you, and then they're going to take the baby as soon as the baby's born. And I was like, okay, well, I'm not going to do that either. So I kind of just did nothing. And that was terrifying, you know, because of course I wanted the best for me and my daughter, but I was just scared. I was stuck. And so I tried to kind of do it on my own. You know, I went to the street and I purchased Subutex off the street on my own. And I was going to try to, you know, go through the withdrawals and detoxes myself. And I ended up getting arrested before I could really do that. But yeah, putting myself back in that moment when I found out I was pregnant, it was just all fear. That's all that came to me. I was just terrified. I didn't know what to do. So like I said, I was just stuck. But had I known that, you know, I had options, my story would be completely different. 100%.
Thank you, Rachel, for, I think, this is something we hear a lot. And one of the things, as a quick side note, right? One of the reasons we hear a lot for not expanding access to these medications is a fear of diversion. But what we know from the data is that the vast majority of people who access what we call diverted or sold out of like the formal channels, right, or accessed outside of formal channels, who people who access these medications this way are almost always doing it like you were, Rachel, right? They were doing it because they wanted to engage with treatment, with recovery on some level for whatever their reason was. And they are afraid to access care. They don't have access to care geographically. Maybe their insurance won't cover it, all kinds of reasons. But people are really scared about diversion. And yet, diversion felt like your only option in this context and was really an act that was in the best interest of your health and your pregnancy. So I mean, I think it shows how complicated this scenario is and the layers of stigma and criminalization and how they're acting on people. So Mishka and Joelle, I wonder if you can talk a little bit, like from a clinical perspective, right? Are these kinds of fears, is this pretty typical of what you hear when people discover they're pregnant, trying to make these decisions? Fear of detoxing and causing withdrawals, fear of medically managed withdrawal. Like what do you see clinically? We can start with Mishka, yeah.
I mean, I think there's like what I would call like legitimate mistrust of health systems and health providers that, people who are pregnant who use drugs experience. That mistrust is born from their prior experiences of discrimination and from the, policy and legal reality of sort of overuse of drug testing and over-reporting to child welfare, from the birthing hospitalization, in addition to now like sort of an increasingly criminalized pregnancy, environment in most parts of the United States. And so I think in this sort of, so I think about it as like through that lens of mistrust, and I would call it legitimate mistrust. And in thinking about that, like, whose responsibility is it to overcome the mistrust? I'm tired of looking at medical records and seeing people documenting patient lied, not forthcoming, as if, whereas I think that's, like, as I said, legitimate behavior. I think the onus of responsibility is really on health professionals and health systems, and then on policy, but to make care safe and make it welcoming, and safe for disclosure. And that's actually hard to do. Um, and so your experience, Rachel, like what you were thinking is resonates. There are pieces, though, in there of what I might call misinformation. The risk, we don't, so that the detox, we'll talk about this, but very briefly, like, detox or medically supervised withdrawal is an acute intervention. Opioid use disorder is a chronic condition. Providing acute interventions for chronic conditions don't make sense. But the risk actually of like a fetal loss, is overstated. We did a systematic review of this. Detoxing in pregnancy does not appear to increase the likelihood of a loss. But detox is not chronic management of the chronic condition of addiction.
Yes, thanks, Mishka. I let you go first. Well, not that it was up to me, but I wanted you to go first because I had way too many things on my list and you just knocked out like half of them. So that's perfect. Yeah, that fear of accessing care, I would say, is universal. I've never met anybody that had a habit and didn't have that fear. Everybody tries things first on their own because kind of the nature of substance use treatment anyway, even if you're not pregnant, is that you need to not have a problem before we help you with your problem. Like you need to detox before we'll put you on meds, or you need to, you can't have any slip ups. You have to basically not have opioid use disorder before people will help you with it, or before they will not kick you out of the program. And so people have experienced that, and they know that that's the way the game works. And so they try to do things on their own. They try to go cold turkey or access MOUD through illicit markets. And that is, I would say, universal. That's what everybody does. As far as fear of detox hurting the pregnancy, I actually tend to see the opposite. Most people who are, if you're a little bit in the field, then you have that idea that detox is uniquely and dramatically harmful to a pregnancy. But most people like who sell drugs, for example, don't know that. And so what I hear from folks is that if you are visibly pregnant, nobody will sell you drugs. And so you end up in this really terrible situation where all of the dangers of accessing illicit drug markets are compounded and magnified. So rather than being able to go to your regular guy, usually, you have to pay somebody else to go there. So you're paying, I don't know, like it seems like it's about 20 to 50% extra for your drugs. You're reliant on that person bringing you back the right amount and not skimming some off the top. You're reliant on another person, which can exacerbate power differentials in abusive relationships that affect a lot of female perceived people accessing drug markets. When you look like me, or if you look like Rachel and you're trying to buy drugs, people automatically see you as a victim and see you as somebody that they can get something from. And that just decreasing your power in those relationships, like it seems like you wouldn't even be able to go down, but you can if you become pregnant. You can lose power in those situations. And so that's a huge risk. I also want to say that sometimes accessing care can be really tricky because a lot of times the detox facility won't take you if you have a medical complication like pregnancy, or let's say right now with xylazine in most illicit drug supplies, there's a lot of places that won't take you if you have a wound. But you can't go to the wound clinic while you have an active substance dependency. So there's really an issue of, even if you could access care that was effective and evidence-based and gender and trauma informed, there's nothing that exists that will help you with all of your things all at once, and nobody has just one thing. And so that's another barrier.
Yeah, thank you for sharing these, both from the personal experience of it and then thinking about it in terms of like what sort of the multitude of people are experiencing and going through in this context. I think one of the things that Mishka brought up that sort of brings us back to, ultimately, Rachel, you were able to get on medications for opioid use disorder. And I think that speaks to, right, when you were able to get care, right? This speaks to what the preferred method of care is, which is treating something chronic, right? And not just treating the immediate possibility of withdrawal and getting, quote, clean, as a lot of people might say. I think one of the things, with outside of pregnancy, we know that non-medication treatment is actually associated, especially right now, with an increased risk of overdose. It's going to be the same during pregnancy if you're not treating long term. So I want to quickly, before we sort of get into the actual journey to getting on these medications, provide just a little bit of information for folks who aren't as familiar with how methadone and buprenorphine work and why they are so effective and preferred. We can go back, keep doing the same order, I guess. Go back to Mishka.
Okay. So I think it's to me, like, one way to think about it is to think about what is the untreated, opioid use disorder state in the context of pregnancy. And there's a lot of false information, almost mythology around substance use, and that people with chronic substance use or chronic, addiction, untreated addiction, when they use drugs, they experience euphoria, they feel high. Most opioids, especially anything you really inject, become relatively short acting. And so people over time, there's like spend more and more time in a withdrawal state, in an anhedonic state, in a, and use barely makes people kind of feel normal. But the real risk of opioids from a pregnancy perspective isn't the opioid itself, it's the repeated cycles of withdrawal of the untreated opioid use disorder state. Those repeated cycles of withdrawal, can cause like stress on the pregnancy, on the fetus, can lead to sort of like premature activation of the fetal hypothalamic pituitary axis that leads to a cascade of events that can culminate in preterm birth and low birth weight. So what medications do is that they stabilize the pregnant person, they stabilize the pregnancy. People aren't experiencing sort of those repeated cycles of withdrawal and anhedonia, and that allows, from a fetal perspective, the fetus to grow normally and overall deliver at term, normal birth weight. In addition, I think of, medications as sort of a platform for recovery, right? By stabilizing, sort of the pregnancy, by stabilizing the pregnant person, you are allowing space to open up, in which people can, engage in prenatal care, be attentive to other, sort of health domains, things about relationships and sort of pregnancy planning. So the key perspective is one of sort of stabilization, and the risk, to go back to that first question, is actually not the drug, but the sort of the untreated state and all of the sort of biopsychosocial spiritual stuff that surrounds, addiction itself.
Yes, that was much more succinct than I could have done. Thanks, Mishka. I only have a couple things to add, and that is that MOUD is immensely helpful for all of the reasons that Mishka just said, and it could be so much more helpful. It could add to stability even more if people didn't have to go to the clinic every day, or even 3 days a week is like a lot. That's a lot to do at the beginning. We need to adjust our protocols, because right now, for example, the main one here in Phoenix, Arizona, where I'm at, they start pregnant and postpartum people at 30 milligrams of methadone, and they go up real slow. And so if anybody's, aware, that's a subtherapeutic dose even 10 years ago. But now with the advent of fentanyl being a much stronger, more potent opioid, people are needing much higher doses. So if you have to, wait 2 weeks to get to a therapeutic dose because that's what the protocol says, then that is just really unhelpful, and it's not giving people the stability they need, and it's frustrating. And it means that people now have to do 2 hustles. They have to go to the clinic, and then they have to go like get well after the clinic. And so we need much more patient control, rather than protocol and clinic policy control. And we need patient-centered care, just like we need in every other health condition that we treat.
Yeah, thanks. That's Joelle, that context. And for folks who aren't as familiar with the way people get different medications for opioid use disorder, buprenorphine is something that can be prescribed by your normal care provider. But methadone, which for a lot of folks is preferred, is only available through opioid treatment programs, these OTPs. And we've written quite a bit about OTPs as a barrier to good care, and sort of the monopolistic control that they have on methadone access. So these are 2 different medications. And I think this is this point of needing more patient-centered care, right? Putting the decision making of this into the hands of the patient and their provider, so that they can do what makes the most sense for that individual, and their particular needs. Rachel, I'm wondering. Oh, go ahead.
I had one more thing to add.
Yeah.
Thank you for reminding me about buprenorphine. That's another protocol that needs to be updated in a lot of places. You cannot do a typical buprenorphine induction with most people's tolerance the way it is right now with fentanyl, because it's just far too high. They're not able to like self-detox before coming into the clinic enough in order to not take that buprenorphine and immediately experience intense withdrawals. And the reason for that is because buprenorphine is a partial agonist, meaning it doesn't turn on all the receptors. It turns some on and it blocks some, and so it can function if you take it while you are in, full-blown habit. If you take it in that moment, then it's going to throw you into withdrawal. So the typical old-fashioned ways that we used to start people on this medication are no longer going to work. And there are not enough clinics that are doing kind of these newer microinduction protocols that actually can work with folks with that higher tolerance. So that's another area that needs to get with the times. The drug markets are just going to continue evolving rapid fire because that's the iron law of prohibition, which is that if you prohibit a substance, it's going to make it more dangerous, more contaminated, and more potent. And it's going to happen much faster than we can keep up with even organizational policy. It's just not possible. So that's just a function of our current system of prohibition.
Yeah, and that's something, I mean, that continual change, right, is part of why we do need patient-centered care. It's part of why we need harm reduction in communities, because these are the folks who are the most aware, right? If we're talking to people who are using drugs, they're the ones who know what's going on the ground and how best to help treat it and make people feel well in those moments. Rachel, I wonder if you can talk a little bit about how things changed for you once you did start taking buprenorphine, and what did that look like from your experience?
Absolutely. So what it looked like for me personally, I was in the jail, and through the jail, they actually over Zoom, they got me an appointment with a doctor, and she asked me all the questions like how often I used, what I was using, if it was just heroin, everything, fentanyl, everything I was using. And then through that, she was able to come up with a dosage to give me, and the jail gave me my Subutex, Suboxone, the buprenorphine, twice a day. And then once I was released from jail and I continued going to the hospital that I gave birth at, I started seeing the family medicine doctor through there. And it was extremely monitored up until I gave birth. I stayed on it. It was monitored. It was safe. It was done very professionally. And I did have to stay in the hospital. Me and my daughter did have to stay in the hospital for an extra week while my daughter did go through the withdrawals. But I remember the nurses there telling me, because as I was watching my daughter go through withdrawals, it was heartbreaking, and I was crying, and I was just feeling just so horribly about myself. And I remember that this nurse, she just got me and she held me and she was like, you are doing the right thing by being on this Subutex. She was like, with this Subutex, we know what it is. It's safe. We know exactly how to help your daughter come off this the withdrawals and the detoxes. And through the street, you don't know what you're getting. So with that, it's just, we know exactly what we're dealing with. We know how to handle it. And just, she even said, just you being here is helping. Like, I couldn't imagine going through that without her. If they would have just taken her immediately and being away from her and not knowing what was going on, they kept me informed. They kept me in the loop. The doctor took all those rumors that I was told in the beginning and just replaced them with the facts and just made me feel so much more comfortable. But that's another thing I wanted to touch on. Even in the beginning, when I started seeing the OBGYN, which this is a very important part, he made me feel comfortable. That was the biggest thing. He walked in and he didn't make me feel judged. I felt zero judgment. I felt no stigma. I felt no discrimination. He made me feel like I was in a safe space and like I could open up and be honest and tell him everything. Because if I feel like I'm going to be judged, I'm probably going to lie to you and not be honest about everything that I was doing, because I'm already feeling so horribly about myself. I'm already, ashamed and disgusted by myself. So I'm already preparing for the judgment that I'm about to face. But he created a very safe space where I felt like I could open up and be honest. And from there, we were able to come up with a plan, and we stuck through it through the rest of my pregnancy up until labor and delivery. And I did want to say I had a very good labor and delivery. It was very smooth. Like I said, we only had to stay about a week while my daughter withdrawal. And I'm so grateful that I was in a place where they believed in me more than I believed in myself at the time, because they gave me, they really opened up that gateway for me. And that was just a really good start for me. I don't know if that answered everything.
Yeah, it totally did. And I think like both your journey to like the fact that you did actually have access to a non-judgmental provider and a non-judgmental experience throughout is sort of a testament to what could be done, right?
Mhm.
And if you think about how that affected you and started your journey really differently, but as I saw Joelle pointed out in the chat, right? It's not necessarily the typical experience.
Mhm.
So we're super grateful for the experience you had and wishing we could help build an environment where things were set up to set people up this way better to have a better start.
Absolutely. Because if I would have felt any other way, I wouldn't have gone back. I just would not have gone back. I
Yeah.
would have tried to do it on my own, like you said, figured it out on my own.
Yeah.
And I would have been led by all this misinformation, like Dr. Mishka said, because all of those things that I heard in the beginning of my pregnancy when I first found out, you know, weren't even accurate. So
Yeah. Yeah, and I think, you know, something it's really we've meant this has come up several times in this conversation about how the stigma and judgment can keep people from telling the truth, right?
mhm,
And or make them want to stop entirely. And it's easy to say, "Oh, well, it's because people are doing illegal drugs and they shouldn't be doing that anyway." Some people are going to go there, but I think it's a really important reminder that people do this in their provider appointments, even if they're taking substances that are stigmatized that aren't illegal. If you
mhm,
smoke a pack a day, you might not want to tell your provider that, especially
mhm,
if you're pregnant. If you enjoy having a glass of wine or whiskey in the evening, you might not want to admit that to your provider. And this is something that comes from both stigma and policy. So, and it's very, very deeply embedded in our systems of care, as well as the policy and the way that it's written a lot of the time. It just is worse because you have potential criminal consequences piled on top of the stigma when we're
mhm,
talking about drugs that are illegal. Um,
absolutely.
did you, I feel like you kind of already walked us through how you got onto the MOUDs to begin with, but it
Mhm.
was pretty, if I remember correctly, it was pretty quick after you were in jail, correct?
Correct. Just being pregnant in jail, you're automatically considered high risk. And the fact that I was using substances, that just put me at like the top of the list. They got me that appointment fairly quickly. It was within 24 hours. It was pretty quick. It was pretty fast. And then I was in jail for another 4 months. And then when I got released, that's when I started seeing the family medicine doctor at the hospital that I gave birth at. And then he basically picked up where the jail left off. But the hospital still knew exactly where I was at, even with the jail. They stayed in pretty good contact, made sure I had my medication. Um, and then even after my birth, I still continued taking the Subutex for about about a year, but I was professionally weaned off to where I didn't really deal with, any type of sickness, because that sickness, that's what gets you, or got me. I should speak for myself. That's what got me. Um, but it was done professionally. I mean, even towards the end, they would prescribe other medications for me to deal with minor things like if I had nausea or insomnia from being weaned down. But it it really went smooth. I'm extremely grateful for the program that I found. It went really, really well. And every time I think back on it, I'm just extremely grateful. And like Joelle said, that's my story is rare. You know, majority of the stories are the opposite of kind of what I'm saying. That I know from other women I know.
Yeah, no, and I mean that's what I hear from folks like Joelle and Mishka, and from reading the literature. It is your experience is uncommon, but something that we're grateful for.
Mm-hmm.
So I think like our street's a policy outfit, right? We think about we're a think tank, so we're always kind of thinking about policy and how we can make policy better for these things. But I think one of the things that stands out with all of this, right, is the barriers to accessing medications for opioid use disorder during pregnancy, right? And these are coming from maybe policy and maybe not just policy, but the application of that policy. And I'm wondering, Joelle, if we can pop to you and maybe you can share your slide or the information from that, because I think it was a
Oh,
really
yes,
amazing
yes.
example of some of the barriers to taking these medications, because there might be downstream consequences or the fear of them.
Mhm. Yes. Am I unmuted? I'm unmuted. Sure. So one of the barriers to policies helping somebody is that policies do not often match what actually happens in real life. So this is some research that I did because I was hopping mad. We, at a facility that I worked at in Arizona, we, not me personally, but somebody in the facility reported this family for using methadone as prescribed during their pregnancy. They reported them to DCS, which is what we call the Child Protective Department here in Arizona. This particular mama had been stable on her medication for 13 years. And according to the law and the policies that you see on the screen there, she should not have been reported. It was not a reportable situation. I will make sure that these slides are available to share after. All of these resources are linked in the slides, so you can check them out for yourself. But basically, the law says that you do not have to report people for taking medication as prescribed. The policy was written out in a pamphlet that we actually gave to all of our families. So that made it feel particularly egregious that we're saying one thing out of this side of our mouth, but then we're actually doing something entirely different. So both of these law and policy agreed. We do not report this type of family, which is to a T what this family was. So me being me, I ran it up the ladder and brought it to the bosses. And this is this is what happened. So at first, I just had a conversation with them. I said, "Hey, we reported this person. Ah, incident. That's bad. We shouldn't have done that." And they're like, "What? Oh, no, we report everybody who's on methadone." And I was kind of shocked. You know, I hadn't been there for that long. As a travel nurse, you're never anywhere for that long. So I just wasn't aware that that was their typical practice. And when I dug a little bit deeper, the boss said that the DCS representative had told her verbally, because I was like, I want to see it on paper. Let me see this so that I can tear it to shreds, right? But it wasn't on paper. It was just something that they'd been told. So I sent them the information from the previous slide. I had, you know, screenshots and links and all of the receipts, if you will. And then I got this email in response. It says a lot of stuff that I blacked out, but after extensive research and discussion with several experts, and if you'll notice, all of those experts are representatives either from DCS or from the state government. So really didn't talk to parents, didn't talk to advocates, didn't talk to lawyers, didn't talk to doctors, strictly spoke to people from the department. And the conclusion was that there's ambiguity in the law, which if you looked at it on the previous slide, just no, there isn't. And said that one of the people that represented the government had mentioned that 133401 said that you have to report, and I think I put it on the previous slide here. 133401 doesn't say anything about what you have to do. It is just a list of psychoactive substances. That's it. So that's just not the case. And the final decision was that we're going to continue reporting all babies with exposure to these medications taken as required. I dropped it at this point because I've been fired 4 times for pushing things like this. And I didn't think I was going to change the organizational policy, and I didn't really feel like getting fired that day. So I did do the extensive research that my boss had claimed that to do. And what I found was, so governments and child welfare administrations, they have just layer upon layer of rules and codes, and it's not just the law and the policy, but I looked at every single one of those things. The program policy said the same thing. If it doesn't meet the definition of neglect in that law on the first slide, it is not supposed to be a report. The administrative code said the same thing. They all referred back to that definition of neglect. The one place where it was slightly different was in the field guide, which isn't really about what's mandated to report. It's more of guidance for the person who's taking that report on the phone. So that one says that if the family is verified to have been stable on their meds, not taking anything else, taking the medications as prescribed, then the concern may not need to be screened in as a report. So just nowhere in any of these just myriad 100, 200, 300-page documents did it say anything about that requirement to report. But that didn't really matter. It didn't matter for that patient and that family. Their experience was, it depended on just what one person said out of their mouth to another person, and that became the law and the policy. And so it's really important to think about as we're making law and policy, we need to think about implementation, but also enforcement. Does this thing have any teeth? Is this just going to be a nice, like, oh, well, you should do this? Because we're used to that. We know what we should do. We've known what we should do about this population for at least 50 years, and we haven't done it, and we're not going to do it until there's a reason to force us to do it.
Yeah, thank you for sharing that, Joelle. It's a really powerful example, I think, of why we did the study that we did, but then also why studies like ours, where we look at what the policy is, aren't where you can stop with any of this, right? Because it does move on. And experiences like that create their own kind of barrier to care for people, right? Like we know that if that just contributes to the types of fears and stigma and concerns that folks like Rachel have experienced when they were initially looking at getting care. Let's go ahead and Mishka, do you have any like barriers to accessing MOUDs during pregnancy that you think would be important to talk about on top of these?
I mean, it might be helpful to just share like a little bit of numbers, you know, and there's a huge range, but if you look sort of nationally, roughly 11% of all adults with a substance use disorder report receipt of any treatment in the prior year. And that number has not, changed in decades, despite like all sorts of work. And that report receipt of treatment may not be evidence-based. Numbers are slightly higher in pregnancy for opioid use disorder. About a third of pregnant people with an OUD report receipt of any treatment in the prior year. So it depends what you compare to the 11, that's more compared to what it should be. Like, 80, 90% of people with depression in pregnancy report treatment, 90% for hypertension report treatment. So there's a real disparity in terms of treatment for this one particular medical condition. But then when you look at folks who enter into, like formal, like, the specialty drug treatment system, people with OUD, at best 50% are receiving any medication. And then you think about, Joelle mentioned that we have over 50 years of data, like attesting to the safety and effectiveness of methadone, and 25 years of data attesting to the safety and effectiveness of buprenorphine. And most of the early literature talks about integrated care, that the best care is sort of co-located service delivery. You get prenatal care and addiction treatment, in the same time and space. What Rachel's story, said, it implies. And that's an even smaller proportion of people who, have what we consider to be the evidence-based care. So the gaps are really less about science, right? And much more about implementation, which reflects sort of will and prioritization.
Thank you. Yeah, that's yeah, I just can say thank you for that, right? Because I don't know, as we try to think about how do we start fixing this, right? It's a multi-pronged, multi-system challenge that we're facing. Which is why, since we don't have any questions in the Q&A, I'm gonna go ahead and just jump into this one last question where what would you want folks who are either like policy lawmakers, hospital policy folks, whatever level of this sort of mess, what would you want them to know about medications for opioid use disorder during pregnancy? Let's go ahead and start with you, Rachel.
I would just like to say that for me personally, it was extremely beneficial. It wasn't harmful. It wasn't hurtful. It only benefited me and my daughter. And it was that gateway. It was that entry way for me into my very long road of recovery. And I just wish that it would be looked at more as like I guess, just not look at it as a criminal act, I would rather it be looked at as, oh, they need help rather than they need to be punished.
And I think, Rachel, you've said it twice today when you're describing it, that it was a gateway. And I think that's something that that policymakers need to recognize, is that people want to get better. Like there's everybody kind of approaches this like we need to tell them they're bad because they don't know they're bad. And if no, like people who have these problems with substances are aware that it's a problem. They don't need that extra stigmatization. What they need is for policymakers and healthcare providers to clear the barriers and open the gate, because they're just they're like the video game character just walking into the wall like over and over. All they need is just get that stuff out of the way, because people want to do this for themselves. That was just kind of highlighting a little bit of what Rachel said. My answer for that, first I'll tell you my pie in the sky in a perfect world, if resources were abundant and unlimited, I would say lawmakers need to just get out of the way, because y'all are a barrier. We need to stop over-regulating these medications. I think the role of policy and law in substance use should be regulating a safe supply of purity controlled and labeled drugs for people to access, because it would be so much easier to kick on your own, to quit by yourself without help, if you could access a stable supply. So many people want to quit, want to cut back, and they start having success with that, but then the next bag you buy has 10 times more potent than the last bag, and you didn't know that. So now you're back to square one, or it's 10 times less potent and you're really sick and you have to scramble to manage. And so it's really hard to wean yourself in that context of not knowing how potent each dose is going to be. So ideally, we would have a safe supply of completely decriminalized and legalized substances that we could all adults could access. But more realistically, I would say something that we could start working on soon in our lifetimes, perhaps achieve, would be to make it so that all physicians, nurse practitioners, PAs, all prescribers are able to prescribe these medications. They do not need to be gate kept so much. To continue on the gate metaphor, we just need to free up that access because, like it said in the R Street email a couple days ago, I think from Jessica, most people who are diverting these meds are diverting them to people who want to use them for their intended purpose. So if we flooded the market with these medications, people would be able to manage their own health and be a lot healthier.
Mhm.
Yeah, and that's definitely something like a fundamental piece of our street's harm reduction stance, right? Is that the government should get out of the way of people protecting their own health and taking care of their own health. So Mishka, if you've got thoughts on sort of last things you want folks to know.
Yeah, I'll try. I mean, so I always struggle a little bit with policy, and even and legislation. If hospital policy I can grasp, it's a bit of a black box for me, and I also approach it somewhat, critically. As has been mentioned, like I feel like there things are oftentimes sort of incomplete, like insufficient, and lead, more often than not to sort of unintended consequences, which can be hard, to anticipate. Plus, I think we overstate the role of policy in affecting, population health benefit and change. I mean, just from through the lens of pregnancy criminalization, you don't need a specific statute that criminalizes something in pregnancy in order to like arrest, prosecute, convict and incarcerate somebody for behaviors in pregnancy. And there's enough existing laws that have been, sort of manifest for that. Now, there's been a pushback in some states with sort of laws that sort of center on the human rights, of pregnant folks. So I would say, like, reflecting what you said, Rachel, just recognizing that people use drugs are people, and also thinking critically about the right to parent and how it's unequally, distributed and policed, and some people actually don't have that right. And keeping in mind that nobody is pregnant because they want to stay pregnant. Like, like pregnancy is about parenthood. It's about family, it's about community. And the sort of denial of the right of pregnancy that happens oftentimes, is really like a gross, human rights, violation, and has been recognized as such by, like the UN and other places like that. But really, sort of for me, I think as long as we're stuck in the box of thinking about drugs first and then pregnancy, we're never going to get out of this. And I think we have to kind of flip the script, like what do people like, what do parents need? And how can we provide what they need? And those needs, like, aren't just for those folks who use drugs, but for actually all, kind of parents. To think about sort of flipping the script from focusing on drugs to thinking about ways that policy and other legislative work can support early childhood development and the family. And that also means, I think, flipping in our heads, the healthcare providers, from sort of an emphasis on saving people, saving babies, to serving.
Yeah, thank you. I love having that as like our sort of final comment because it's a really powerful recognition, right? As we move to acknowledging humanity and autonomy of individuals and people who are wanting to go through pregnancy and have that child. And if we can support them and, as you said, Mishka, serve them in a better way, that might be a really useful reframing for thinking about everything from policy to practice. So, yeah, I just want to thank all of you for joining us today, to our wonderful panelists, and to the audience for your for being here and listening to us. So thank you very much, and we'll see you next time.
Thank you so much for having me.
Thanks all.
Yes, thanks for the
Thank you.
invitation.
Thank you.
My
Bye.
pleasure.